was wrong. Wouldn't be starting spinal next, would be starting splinting. And there's long bone splinting, and then there's joint splinting. And they're very, very similar. Just a couple of little things different that we'll talk about with that, but those will be the next two skills that we'll be working on. Two big things: make sure you get a splint that's big enough when you splint someone, and make sure you always reassess circulation, centering, motor afterwards. Those are the two things that I see a lot of people miss when they're doing their skills job.
Are we looking at rigid or semi-rigid?
We'll practice all of it.
Okay.
Most of what we have and we check with are the preformed Velcro, semi-rigid foam type splints. Although we do have some boards that we can splint with, and then we have the triangular bandages for sling and swath. We have some vacuum splints. I think they have a bit of a leak in them, so they're not going to be like perfect, but they work pretty well for class.
Okay.
Maybe even get out the mask pants and talk about those too.
Oh, that sounds cool out there.
Yeah, but I still want to at least make people aware of what they are in case they see a test question. This is kind of an easy one for us, because you walk up and you see someone's arms off at some weird angle, or they have this new joint, and you're like, that's broken. That shouldn't be like that. So we can generally identify these, although we're not going to always be able to see it that obviously. There's a lot of times we get small fractures and things where it's not all that obvious externally. This is one of the times where we may change our assessment a little bit. So we know we start off with our scene assessment, scene survey. We get through all that. We do our primary, where you get your general impression of looking for life threats and your airway, breathing, and circulation, and get the vital signs and make a transport decision. And then we start a secondary, which up until now, for the most part, has been kind of a head to toe. But there's also this focused secondary assessment that we can do, and that's like the guy that fell off the skateboard and broke his arm, and you know his arm's broken because you can see that, and he's holding it, it's really hurting. I don't necessarily need to do this whole head to toe and look at everything, and he's like, it's my arm right here, right? As you're working your way down, and can you move your arm so I can listen to your chest? I was like, can you just split my arm? So we can, if we think we have an isolated injury like that, do a focused assessment, which means after I look for life threats, mental status, make sure my airway, breathing, circulation is good, got some baseline vital signs, made a transport decision, and he says, all I did was fall off my board, my arm's really hurting, I don't have to do the head to toe, I can just go to the arm. And then I look at the arm and go, oh yeah, that looks deformed, we'll put a splint on it, can you wiggle your fingers, capillary refill, pulses, good. So we can do a much more abbreviated assessment. Now, which assessment we do is dependent on what you think happened to them based off of the mechanism of injury. So this is a guy that fell down a flight of stairs and said my arm hurts. I'm still gonna do a head to toe on that one because he could have injuries all over the place, I don't know. Or a guy that just caught his arm, said he felt something snap at his arm, then I have a much less mechanism and I can look just at that. I probably need something for that. So musculoskeletal system, we know muscles give us shape, allow us to move. If we move them enough, we can generate heat, burn through some energy, and provide some protection. And we break these into a couple of different types. The voluntary muscles, just by the name voluntary, is the ones that we can consciously control. So me standing here and waving my hands around and all that is voluntary muscle. And I have to consciously think, and that's kind of an interesting process. So if I want to pick up my cup to get something to drink, I have to have the thought in my head, and somehow that thought then becomes an electrical impulse that goes down the nervous system to my arm, my fingers, and my hand to pick that up and move it. And how that really all happens, I don't know if we fully understand how a thought suddenly becomes movement. Just kind of cool. So, now skeletal muscles, or voluntary muscles, really can only do two things. They can contract and they can relax. So most of these are found in a muscle pair or muscle group. I'm recording the lecture tonight because most people were saying they couldn't make it because of the floods. So we're going to start with this, and then we'll take the test, and then we'll play with some splints.
That'll work.
So contraction and relaxation. So if I look at like my bicep, tricep, we think of them as a muscle group because my bicep will do this. But my bicep can't push my arm back. All it does is this. So I need an opposing muscle group, the tricep, to come back the other way. So when I move towards my face, bicep, try to relax the tricep, and then when I move away from my face, I relax the bicep and contract or shorten the tricep, and I go the other way. If you try to do both at once, and you kind of freeze your hand in place, and it's hard to move. So for most of our voluntary muscles or skeletal muscles, we have some sort of opposing muscle group. And typically when we think musculoskeletal injuries, these are the ones that we talk about. So we also have the involuntary muscles. And remember, involuntary muscles are the ones that like control how big or narrow, constricted or dilated your bronchioles are. They control the movement of food through your intestines. They constrict, dilate blood vessels, stuff that you don't have to think about. But nobody's ever been like, oh my goodness, I think I just pulled a muscle over here in my left mainstem bronchus. We just don't ever pull or injure the involuntary. It can happen, I guess. We just never really think about that. That's something to ponder now.
What chapter are we going over right now?
This should be 30 musculoskeletal injuries. I had it in my head that we were kind of all the way up to 32. I don't know why. I guess I read it wrong last night. Then I was shown the error of my ways and had to go back to 30. Or I had picked up and looked at the wrong week on the calendar, which is possible. So tendons and ligaments, which work very closely with muscles and very closely with bones. So a ligament connects two bones together. And I kind of remember ligament is bone to bone. L comes before T in the alphabet. And then tendon does bone to muscle. And M is later in the alphabet. It's just a weird way for me to always remember it. Ligament to tendon. So ligaments, bone to bone, tendon is muscle to bone. If it's any consolation, out in the field when somebody has a twisted ankle or a sprained knee or whatever, you're never going to go, oh, it's that ligament that's hurt or it's that tendon that's hurt. We can't really tell that in the field. We just go, yeah, your joint's messed up because put a splint on it. Now, if you want to go further in your education after EMT school and get into athletic training or physical therapy, there's a course called kinesiology, which is a really, really challenging course. But if you like this stuff, it's really cool. Where you learn every single muscle in the body and where the origin and insertion of it is and what it does and the tendons and ligaments and all that. And then athletic trainers and physical therapists have all these little tests. So if you move your knee this direction and you flex your foot this way and it hurts at that point, it's that tendon. And if you flex your knee this way and you bend your foot that way and it hurts at this point, then that's a different tendon. And they have all these little tests to be able to identify what hurts and what doesn't and what it is in the body. Which is an incredible body of knowledge. It's just cool, but not all that practical for us on the typical ambulance. Start doing a lot of sports medicine type stuff, standing by football games, helping out with those. You might want to learn some more about it. It's just cool that somebody can do that and keep all that stuff straight. I'm much more with like just getting an MRI. That works. Now our joints have this capsule around them. And inside of this capsule, we have a little bit of fluid, a little bit of oil, called synovial fluid. And that fills in the joint cavity. And around the end of each bone, we have cartilage, and they call it articular cartilage, but there's other types of cartilage. But this cartilage is extremely slick. And if you ever want to see it, go get a chicken leg, and you can see the cartilage at the end of the bone. It's pretty darn slick. Smooth. So a little bit of fluid in there, a little bit of oil, and these things should hopefully move and slide past each other without much friction and without us really noticing, unless you develop a condition called arthritis. And then your immune system can attack and destroy this and inflame all this, and then it's like some sandpaper moving past each other, and that's really, really painful.
Yeah, I've got arthritis in my fingers, my hand and fingers, thanks to my doing stupid infantry stuff when I was a kid. And yeah, even this normal weather, it's still, it hurts.
So rheumatoid arthritis is when your immune system is destroying it. Most time we say arthritis, it's probably something that we've done and we've injured it over the years. Kind of wear out that cartilage. You have cartilage that can kind of like tear and break loose. It happens in knees a lot, and then they kind of catch and hang up, and then they go in there and clean out the knee.
Had that done.
Just cleaning all that out, taking that all out. Just realize that you're getting closer and closer to getting bone on bone every time they clean out a little bit. And that can be a,
I had some damage to my LCL and, my patella, and they went in there, back row, and, cleaned it all out. No, that hurt.
there's not a lot of blood flow to the inside of a joint, so this stuff is not gonna heal very well in this area. Although they can do some artificial type cartilage and stuff that they try to put back in there, it's just never gonna be as good as the original stuff we had. My wife who does physical therapy at home, home health stuff, primarily she's with little kids, but she does occasionally do some stuff in home health with older people. And I've had patients tell me this, it's been a while, but she still, to this day, well, every once in a while, a couple times a year, maybe comes home to, not gonna believe it, and another one, what do you mean another one? Where she'll be going to some old timer whose joints are all stove up. And being from Wisconsin, I didn't know what all stove up was. She had to explain that to me. I'm like, all stove up. Stove is what I put like wood in to keep me warm in the winter. That's what I thought stoves were. But apparently you get all stove up, which means you're stiff. So there are still some people out there that think WD-40 is a wonderful way to loosen up joints. And that might work really good for the hinge on the door. It does not work for your elbow or your hip or wherever else they're spraying it. But she'll get there and she's, do you spray something? They're like, oh yeah, I put WD-40 on my knee, it's really been stove up. She's like, that doesn't work. Oh yeah. I sprayed it on there and I'm all better. Okay, I don't think it'll hurt them, so she just kind of humors it, but don't recommend that for your patients. That's not accepted medical treatments. So some ways we can do things. Move joints. We can flex joints, which is bringing them in like this. We can also, whoops, I went too far. That's what happens when my finger hits the slide. So we can flex, which is pulling it towards us. Extending, which is generally taking it away from us. Adduct, which is bringing towards us. And then abduct, which is taking away from us. Rotation, and this was an interesting one to try to figure out how to rotate, but I'm rotating around like the humerus at this point. So I'm rotating around that bone and these joints. And then you have circumduction, which is just a big motion, and these generally are going to be hip and shoulders. Not all joints will move in all ways, but these are some basic ways that they're going to move. So these things can get hurt. And when I look at that, I go, ow. Glad that's not me. Open versus closed. So some people will call this, there's another term I was going to use, it just slipped my mind. Anyways, an open fracture, or compound fracture, that's the word I was going to use. That's kind of an older term, a compound fracture. So that means that the skin around the fracture site has been torn. Now that could be because the bone ends went right through it, or it could be that they had a cut and a snap in that area, and they didn't really come out and come back in, but we don't know. But all I know is we have a wound, so there's a break in the skin right over where we think we have a fracture. So if we have any of that, we're going to consider it an open fracture. The bones don't have to be sticking out through the skin. Although when they are, you're like, ha, yeah, that one's broken. I don't even need the x-ray, I can tell. The biggest concern with that, with open fractures, of course, is infections. Get ejected from the car, fly through the air, not on a day like tonight when everything's so soft, but maybe a little bit drier day when the ground's a little bit harder. They hit the ground hard, arm breaks, radius solid come out through it, stab into the dirt. Bunch of grass, gravel, and stuff like that on the bones, rinse that off. You're talking about irrigating wounds. We're not going to spend a lot of time, we're not going to truly flush it like you might out in the field irrigate, but rinse off the gross stuff. What I mean by gross stuff, the stuff that you can see, the big stuff. Then cover it up with a 4x4, something like that, and then we put the splints on. If it's closed, just put the splints on, not a problem. Now, whether it's open or closed, typically these things are going to hurt. there might be some deformity, some contusions or bruising to the area. They may have some abrasions. They may have some penetrations to the area, tenderness, lacerations, swelling. In fact, if you can remember something called DCAP BTLS, which we'll talk about, or DCAP BLS TIC, and we may have already touched on that with patient assessment, but that is what we're looking for as we're going over the bones to see if we have any injuries. Those are signs and symptoms. Now, complications, long-term with this, I do worry about arthritis buildup. Nothing I can do in the field that's gonna fix that or make that any different. And short-term, the biggest thing that I worry about are these bone ends going to push against an artery or a nerve and kind of cause some damage. So when we are taking care of these wounds, we need to make sure that we assess the circulation, sensory, and motor function before we splint something and after we splint it to make sure that it, I may get some a little bit, kind of hard to lecture and eat, but thank you. But if I have these bone ends pressing on an artery connected to tourniquet, so I need to relieve that or straighten it a little bit, same thing was pressing on the nerve. So we would get one attempt, if they don't have circulation or sensory motor, to kind of put it back. So if it's like this, you would get one attempt to kind of straighten it back out into its normal position, and then splint it. Unless you're like, it just won't move. Don't be like trying to force it back into place. Or if you start to move it back in, they're like, ah, and then just screaming and yelling, and it's just way too much, just leave it. Splint it that way. Take it to the hospital, we'll dope them up really good, then we'll straighten it out. But they're probably gonna have surgery at some point anyways for this, because if it's that bad of a fracture or the bones have moved that much.
Yeah, that's gonna need pins.
Yeah, they're probably gonna have some pin or something on it. Now, we always have to mention osteoporosis when we're talking about fractures and musculoskeletal trauma, because you or I can take a pretty good fall right now, but as we age, our bones get thinner and weaker, and a lot of our elderly patients are just like walking across the floor and their femur snaps, the head of the femur snaps off. And when that happens, of course, then they go down and they fall. So a lot of people say they've had a broken hip because they fell. And it's really not that they fell and then broke their hip, their femur snapped, the head of it, which is right here in the hip, so we still call it a hip fracture, even with the femur fracture. And because that's bone's broken in half, they fall over. But that's osteoporosis. The other thing we need to worry about is the little old lady, little old man that gets up in the middle of the night, go to the bathroom, trips and falls. You or I do that in the middle of the night, and we're usually cussing, really mad at whatever we tripped over. It's always your pinky toe. So now you're at a pain scale of like 37, but you're okay. But somebody older falls and does that, and suddenly they have a broken arm, they've snapped something in their neck, so the fracture risk is much higher for those that are older because of osteoporosis. Now, a few other things that we can do to ourselves, we can have strains and sprains, and these are typically muscular or tendon ligament injuries. Very hard for us to tell the difference in the field, and really there's not much of a difference in treatment. If something is strained or sprained, for the most part, if the body part's hurting them, we're going to put a splint on it. Maybe an ice pack, and we'll take them to the hospital. Now, a dislocation like a shoulder like this, we are not supposed to pop it back in place.
Yeah, we don't have the training for it.
Yep, we theoretically don't have the training for it, and there is a risk that if you pop it back in place, you could press on an artery nerve and cause some damage. I have had many of these pop back in place on their own when I've been trying to splint them. You're like trying to get the sling on it or something, there's a pop, and you're like, oh, hey, that feels good. Can I sign the refusal now? And generally, I'm okay with that. You know it's back in place typically when they can touch their opposite shoulder. It's usually back in place. Now, sign the refusal, take them to the hospital, get an x-ray, all the risks of complications with it, but.
Because you want to track perfusion and color, temperature, stuff like that afterward to make sure that there isn't an injury to a nerve or the arterial system in the shoulder.
And some of it is dependent on the mechanism. So somebody fell over an outstretched arm and they dislocated their shoulder. I'm not as keen about letting that one sign a refusal because I'm afraid there's something that might be broken in there. Where somebody is like going to throw a ball and suddenly it pops, they probably didn't break the bone. It's just like, oh my goodness, that's in the wrong spot. And I don't mind that getting popped back in, but again, we're not supposed to do this, just this stuff happens or people reduce it on their own sometimes. I wish we could put shoulders in officially. Wilderness medicine, they teach us how to do that, so that's kind of cool, mainly because if I'm like 12 hours on top of a mountain, I'm not carrying your pack that far. Then put your shoulder back in and then you can carry your own pack. I wouldn't do that to them, but that's kind of a thought. Kneecaps is actually one I think we should be able to learn how to put back in, because if we can pop that back into place, there's usually not a complication with that, and then they can walk. So, ways we can hurt this, direct force. So the person that trips and falls and has their arm out, what's probably gonna break?
Wrist.
The wrist?
That happened when I broke my wrist before.
But the wrist doesn't touch the ground, my hand touched the ground.
And the hand touches down, but the force of, body motion tends to stay in motion unless the outside force acts upon it.
Well, the ground and my hand acted upon each other.
Well, that was to stop it, but you still have, it wasn't enough, resistant force to stop you from moving.
So the direct force is the ground and the hand. And if my hand is bruised, that's the direct force that caused that damage. The indirect force means it was transmitted up the bone a little bit and the wrist snapped. So a lot of times, it's not necessarily the part that hits the ground that breaks, it's force gets transmitted to something else and that part can break. So we can have fractures a little bit further away. Cause you'll see somebody leave like an outstretched arm and then they'll break something up here or a clavicle will snap. You're like, how did you do that? Well, that's just the indirect force traveling up that far. The other way we can do it is we can plant or get a foot or an arm and then twist, or a piece of machinery, grab your arm and twist it and snap it. And we don't get to see this pre-hospitally very much, but on the x-rays when we bring a patient in later and the doc's like, hey, you need to check this out. These are how the bones oftentimes break. Now the comminuted sometimes I can expect where it kind of hits and more or less just sort of blows out. It can be a real bad one because all these little bone fragments aren't going to heal back together like they're supposed to. So either they can have a shortened bone or they have to put something in there. This impact where you get a bit of a crack and splintering is fairly common. We've probably seen the transverse. Transverse and oblique are really kind of hard to tell the difference in the field until we see the x-ray. Because here the bone ends have separated, and if they separated and slid past each other a little bit, or if they just separated side to side, it can be hard to tell. These, we sometimes, the spiral fractures, can get an idea or think that may be what they have. I see these primarily with sports or with the industrial thing, where the person has stepped and twisted and something in the bone twisted and snapped. Now the green stick we see almost exclusively in children. And I was thinking about this when I was out in the woods the other day, but I didn't want to take a branch off of a tree that was still alive and all that, trying to leave no trace and all that. But if you can imagine a green stick, if you ever tried to break a stick that's not dried out, you end up with like, and the thing just won't snap. But you end up with it kind of splintering on one side, and that's the green stick. Kids' bones will do this because they haven't fully formed yet. So they can have a fracture that's just kind of broken on one side. Good news is that type of stuff will actually heal pretty quickly. It may not even get a cast. Splinted for a week or so too. Good news. Now we do have a few fractures that we consider kind of critical, primarily because of blood loss. And pelvis is the biggest one. And I've heard all sorts of numbers, from 500 to 1,000 cc's of fluid loss for every fracture. But you know, you have the aorta that comes down and it has split into the left and right femoral artery that pass right through the pelvic cavity. So these bone fragments can cut those arteries and you can lose a lot of blood. Now, how much space do you have in your pelvic cavity? You can take your entire blood volume and fit it in there. So you can fit all of your blood into your pelvic cavity. So you cut one of these femoral arteries internally, and they can bleed out. You take all the blood they have and put it right in there. Now it's gonna be a little swollen, might look a little discolored, might be tender, but pelvic fractures are a concern. So remember how we assess for pelvic fractures?
When they're in the prone, we push down
Yep.
lightly.
Post,
on the,
push
on the
posterior,
press
and then we push
in.
in. So we push down and in. Don't rock them. We used to rock the pelvises, we don't do that anymore. Now, if you push in, you push down, and that doesn't hurt, you can put your hand on their symphysis pubis and try to palpate that a little bit, see if that's broken. And if none of that elicits pain, then you're okay. I had one not too long ago. She had fallen, I think it was a nursing home. And I flipped into teacher mode before I thought about it, because I was doing my assessment on her, and she was on the floor, and I pressed on the pelvis, and I felt it move, that crepitus. It's kind of like, ooh, ooh. But my partner was also one of my paramedic students. I'm like, hey, you gotta check this out. She's like, what? I'm like, you need to feel this. He's like, oh, what's that? So that's crepitus. And the firefighter's like, well, what's that? I said, well, come take a feel of it. And I'm like, oh, wait a minute, no, we don't need to do this.
To the left.
Teach that.
That's a lot of things.
Yeah, she was pretty out of it, so when we pressed, there wasn't like a whole lot of, she didn't moan or anything, so I don't think we were hurting her much, but about the fourth person, I'm like, oh, wait, no, I don't, let's package her, or take her to the hospital. But then there was a nursing student that was at the hospital, and I'm like, we need to check this out.
So how did you put that on the board? Did you put a pelvic sling on it?
Yes, we use pelvic slings. It was interesting because when they first kind of hit EMS, everybody's like, oh, this is awesome. And now they're like, there's not really a lot of evidence to show that this helps. But I have my experience with the pelvic slings, both the pre-made ones and then the roll the sheet up and wrap it around them. My patients have always felt better afterwards. There's always been pain relief. So I still think they're good until they tell me that they're harmful. They just may not stop bleeding and be as beneficial as they once thought.
Well, they're beneficial to the pain control, it's beneficial.
I think so, but I don't want to do pain control if it makes bleeding worse. Initially they said it made it better, but now they're like, we're not really sure about that. We're not seeing that.
Yeah,
So.
because doctrine, I hate bringing up military stuff. Military doctrine is usually pain is the patient's problem. When they've got an injury on a high LZ or something like that, yeah, they're in pain, but quicker you can get them packaged and get them out of there, get them to a flight medic who has the good stuff.
To a certain extent, yeah. And that's even in civilian medicine will do some of that. So if this helps with pain, I'm fine, but if it's gonna make the condition worse or the recovery worse, or they can't do surgery as quickly or something, then there might be complications, and I don't wanna use it. So we're still using them, still think they're good, just don't be surprised if in a few years somebody's done a decent study on these things and they go, oh, that was dumb, don't do that. And you can say, well, Mr. Hoy told me that we're supposed to. I'm warning you now, that might be one of those things that's changing. So that's one that's a concern primarily because of blood loss. The other one that's a real big concern is a femur. Because again, the sources may say a few different things, but I've heard all the way up to 1,500 milliliters of fluid can get lost into your thigh. But I like to think that my thigh muscles are just so that I couldn't lose that much in there, but yeah, I can. So if you have one of these and you lose 1 liter to 1.5 liters of fluid, I only had like 5 or 6 in me to begin with. So now I'm starting to push that 20 to 25% blood loss, which puts me into like stage 1, stage 2 shock. Now something happened and I break both of them. Well, I only have 2 or 3 liters of fluid loss, blood lost into my thighs. And that's half my circulating blood volume. So now I'm in like really, really profound stage 3, stage 4 type shock. So bilateral femur fractures are a problem. An isolated femur fracture, we can use some sort of traction splint, and it takes time. They're not always the best devices, but again, like with the pelvic sling, my patients, every time I've used them, and I've only probably used them 6 or 7 times in my career, but I put them on, I stretch them back out, and the patient just goes, oh, thank God. And to me, that's like cool. That's worth it. That's better than morphine, fentanyl, whatever. I can stretch that out and then just whew. But it does take some time. And I am, in theory, reducing a fracture, which some doctors really don't like us doing because we're worried about causing more damage as we move those bones. Although we're basically doing the same thing they could do. They just went to school a lot longer than we did. So when we're doing this, like every other call, BSI, scene safe, or what hazards do I see, mechanism of injury, how many patients, additional resources do I need to consider C-spine? And a lot of times you do have to consider C-spine with this. although not always, but you may have to consider C-spine depending on the mechanism of injury. And you were asking me about my thoughts on C-spine earlier, and I'm cool with the collar, I'm cool with holding the head still, although most of the time if somebody has broken their neck or back, they're not like, hey, what's going on? They're more like, oh, my neck hurts. And they're not like moving around anyways, most of the time they're doing this. I mean, you've probably woken up at some point in time in the morning, you're like, oh, I slept funny.
Yeah.
And you're like, oh, this really hurts. When you break your neck, that's kind of what it's like. You're not, whoo, oh yeah, okay, I'm good. So they're self-splinting a lot anyways. But putting them on a backboard, not so cool. But there's a couple of times for this we might. So they've broken a femur, and they've broken an arm, and they have a neck, put them on a board, strap everything to the board, everything's splintered. So there might be some times that we're still gonna use it. But this assessment sheet, anytime you see a question on a test that says, what would you do next? They're really asking you, where are you on the assessment, and what's the next step? So this I can't stress enough to memorize. Now, one of the things that we oftentimes will do with these musculoskeletal injuries is all of us watch the baseball player, and when the guy stepped on his ankle and we saw it snap and went, ooh, in fact, you heard the audience, they all went, oh, you could hear the crowd. So we sometimes go like, ooh, that's really, really gross, we need to do something about that broken ankle. Where in reality, the ankle isn't gonna kill him. That's a minor injury. Painful injury, looks gross, but it's pretty minor. We need to make sure that we have a general impression of the patient, check our mental status, look for life threats, see any major bleeding, control that, make sure the airway's open and clear, and they're breathing adequately. Do I need to put them on a little bit of oxygen? Check radiocarotid pulses, skin condition, refill. Check for any other bleeding, keep the patient warm if you suspect shock, get your baseline vital signs, and priority patient. Make your decision. After that, and really this should just take, I don't know, 10, 15 seconds, check a pulse, check breathing. It's not that long. Now, if you're like, oh, I see him squirting blood, remember, the National Registry of the Assessment says, partner, go put a tourniquet on that, and you keep going. So it should not take you long to do this part. If you see something though, that needs to be fixed, you can kind of assume your partner's gonna do it. Now in real life, I don't always have like 30 partners standing around waiting for me to tell them what to do. I have like me and my partner, and he's busy doing something. So I might put the tourniquet on them before I really get to continue, because I'm the only one there. But if you have help, let them do it, you continue the assessment. Only 2 times we stop the assessment, remember what they are?
Life, limb, and eyesight.
Only 2 times we're gonna stop doing this whole head to toe assessment.
Lost pulse at CPR?
Yep, CPR, no pulse.
And seeing,
Well, we haven't even gotten to it at that point, but yes, before, I'm gonna say once we've gotten to the patient and started the assessment, barring any hazards, they tell us airway obstruction needs to be cleared, no pulse, we start CPR. Other than that, we should continue our head to toe. But you're right, if I'm in the middle of like, hey, are you okay? And somebody, he wakes up and pulls a knife out, I'm out of there. I'm not continuing my assessment. Fred, I'm out of there.